So with that, I'd like to go into my first presentation and show you some of the very basic background understandings and things that we think lead to dysfunction in people living with HIV if we look into their immune system. Just to start with, just the disclosures, I'll start with some remarkable case histories from my outpatient clinic. Very briefly, this is a patient who was diagnosed with a Burkitt lymphoma in his 50s, and an HIV test was done and he was found to be HIV positive. And as you would expect, advanced disease, low CD4 cell count, a lot of virus, a very sad situation. The patient was treated, started chemotherapy, and unfortunately died a few months later during this treatment. He was married to his wife, and his wife was positive as well. And you see, upon diagnostics on the HIV, completely different situation. Stable immune system, virus hardly detectable. Of course, she was positive in the tests and also had proviral DNA, but she turned out to be, over the next years, to be an elite controller. We've got to assume that this is the same virus. And it's remarkable how the same virus in different people can lead to completely different situations. This is what we know for many years, and this is very complex. I just wanted to highlight this at the beginning because the elite controllers have privileged immune systems and some other conditions that make them being able to control the virus. What we all know, HIV can infect CD4 T cells, but we've got to assume that the loss of CD4 T cells not only happens due to the infection with the virus, but by many other things. Why are CD4 T cells so important? They guide and orchestrate so many functions in the immune system. They support the function of B cells, which then in turn produce antibodies. The funny thing is that in most people with HIV infection, antibody production goes on mad and is overly produced, which is a specific form of B cell dysfunction. The CD4 T cells also support the generation and differentiation and the effectivity of cytotoxic T cells, the CD8 T cells that we require for cancer rejection or control, and also control of viral infection. And lastly, this is why people with HIV have issues if they have also tuberculosis infection. They cannot control as good as others intracellular pathogens because the CD4 cells help macrophages to control and destroy intracellular pathogens like tuberculosis. So the loss of CD4 T cells is not the only issue. We've learned that persistent antigen presence can lead to dysfunction. If naive T cells are primed on dendritic cells, they should go into a differentiation process. They should proliferate, produce cytokines, and become cytotoxic, or in case of CD4 T cells, have other functions. And we've learned in HIV and in other persistent chronic infections like hepatitis C, and we've learned it also in cancer, that another regulatory mechanism can stop the T cells from working because there's a sort of break in the immune system. Whenever there is stimulation, there's also a break, and there is a constant break. We find T cells in people with HIV dysfunctional. We can reconstitute this, we can interfere with this receptor system, and we do in cancer treatments and all these modern ones. We can do this experimentally in models. We've done this in humans as well, but we can't really make perfect use. HIV-specific immunity is not easy to reconstitute and to improve. So we've got to assume very often, even in patients that are treated, that their T cells are lazy, exhausted, and less functional. Immunologists have a great fun in subdividing T cell population into different subpopulations, and this is a very still simplistic view of naive central memory or effective memory T cells. And these ones are distributed differently in the body. The central ones are more in the lymph nodes, the effector memory T cell compartment more in the gut mucosa. And this is for good reasons, because these effector memory T cells have on the surface chemokine receptors that guide them through these locations. And you see CCR5 again, and you can imagine that turns into an issue because that makes these cells susceptible for HIV infection. And that's indeed what we see. In various models has been shown in animals, in monkeys, but also in humans. What happens during the acute phase of the HIV infection is that many of these T cells, the mucosal ones in the gut, are depleted and destroyed very early on. And even start of treatment against HIV does not fully reconstitute this. This has changed the view about 10, 15 years ago when we thought initially there is little loss of CD4 T cells, and it's different. The first cut is the deepest. Some people say the acute infection leads to a severe cut into the immune system, and that has consequences. This is another cut through the gut and shows the lumen and the CD4 T cells in the mucosa area, shown here in red. And so if I put in HIV, these ones are infected and destroyed. And that leads to, as a consequence, because these are specific T cells with specific questions or responsibilities, that leads to a dysfunction of the permeability of the gut mucosa. And that is a harmful effect, because now products from the commensal bacterial colonization in the gut can start to constantly transfer and go into the circulation, lipopolysaccharides, and that's what we see in people infected with HIV. That in turn leads to more activation of the CD4 T cells, which makes them again more susceptible for HIV infection, and that perpetuates this damage. Again, starting HIV treatment stops this to a certain degree, but there is a constant and persistent flow of bacterial products that we see. And the gut mucosa is more complex, more immune cells are in there. I've put in plasmacytoid dendritic cells, macrophages, and then the whole picture becomes more complex. We see that these cells, plasmacytoid dendritic cells, macrophages, can be infected or recognize the virus. They produce interferon, for instance, or TNF-alpha. The macrophages are activated through lipopolysaccharides from the bacteria. And all these levels of cytokines we find very often increase in people living with HIV. That leads to immune activation systemically and destruction of the lymph node architecture, which in turn, again, is important for the function of the adaptive immune system. And the longer this persists, the worse it gets. And we've learned that this is not harmless. We have always the challenge of defining and measuring what inflammation is. Inflammation is a very messy concept, I must say, in immunology, and a very flexible one. But we see that some of these surrogates that you measure in the circulation are associated or predict outcomes. And it's not only mortality, we can correlate some of these surrogate markers to comorbidities and lots of other things we're going to discuss in the next talks. I'll put it sometimes in a different picture. There's a lot of inflammation in people that have untreated HIV infection. We can reduce this with HIV treatment, but there is a remaining issue, and where this remaining inflammation comes from, whether that is remaining virus, viral replication, or other viral products, we're going to look at. And that is apparently a bit more than we see in people without HIV infection. Probably this comparison of there is still a bit of inflammation is also one of the explanations why lipid-lowering therapy with statins, which also has a sort of off-target secondary effect of anti-inflammatory activity, is active and more efficient in people living with HIV. And this could be the effect, explaining the differences that we see in the rates of myocardial infarctions in people living with HIV as compared to people without having the virus. At the same time, I'd like to put a caveat. It is not always, and it always, in all circumstances, the virus. We do see, for many years, it's been confirmed by various groups, surrogates of T-cell and immune activation in people living with HIV, and very often these studies were done in comparison to healthy controls. And what a healthy control is a matter of definition. And I like always to refer to the Dutch group, if you ask others and would consider them as healthy donors, MSM, for instance, that have no HIV infection, you'll find some degree of immune activation also in them, which would mean, okay, it's not all HIV, there is lots of other factors, other co-infections, behavioral things that could impact and influence surrogates of inflammation. So I'll put another one next to this healthy donor in the MSM with ART. Just to make aware, it is always complicated. We always have to look into what is the comparison, what's the background, what is the context if we look into inflammation. This last figure summarizes much of what I've said, particularly the lower part with the gut pathophysiology and immune dysregulation and immunosenescence, because the T cells and others proliferate and age more, they are more used as compared to other control measurements. We do see impact of co-infections, particularly CMV, as we do see this, of course, in people without living with HIV. And to end up on the top left, there is the question of HIV production and replication. We all think that with ART, we perfectly block viral replication. There's been lots of studies looking how complete this stop is. And we've learned so much about the composition of the latent reservoir, whether there is a replication ongoing. But there's more and more discussions that could be, despite block of viral replication and no measurements of RNA in the circulation, that there could be aberrant production of viral products, of proteins, incomplete viruses that cannot continue to replicate, but there could be sufficient material circulating, I put it in simple words, that continues to stimulate the immune system by various degrees, despite having HIV treatment perfectly measured and confirmed. We looked with target not detected assays and blips and all these sort of things. And we know that clinically HIV therapy is very, very efficient. But we're now thinking about the people that carry the virus for 50 years now in the future. Does it matter? Does the treatment that we give completely stop viral replication, or is there more that we need to do? So I'll leave it there as a setup for the next two presentations.